Hello again, everybody. Welcome to case study number 24. This will be a young woman coming in with chronic pain, and that always sends shivers down the spines of med students and residents because it is notoriously difficult to work up. So we're going to work our way through this, remembering that you really got to pay attention to unique symptoms that may be present. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button on the upper right-hand corner. I really appreciate all those of you who have contributed and those of you who are considering contributing. Really helps me out. So thank you in advance. All right, we got a 29-year-old Chinese-American woman coming into the clinic complaining of intermittent joint pain and fatigue for 9 months. She says she avoids going to the doctor because of health anxiety, but that her symptoms have gotten so bad that she can't focus on work the way that she needs to. She says that she feels pain in all of her joints, but particularly in the fingers, wrists, and ankles, so peripheral arthritis or arthralgia. The pain is worse in the morning and gets slightly better throughout the day. Hint, rheumatologic. She's tried ibuprofen, acetaminophen, but neither has helped. She works as a biologist. She's monogamous with her husband, doesn't drink, smoke, or use recreational drugs. Family history is non-contributory. She's got a past medical history of major depressive disorder and 2 miscarriages in the past 3 years. Medications include paroxetine and a prenatal vitamin, vitals. So her blood pressure is slightly elevated. Her temperature is slightly elevated. And look at this. She's 5'4" and currently weighs 107 pounds. A little bit underweight. And that's down from 125 the last time she checked last year. And she hasn't intended to lose this weight. She's lost about 15% of her body weight. So we're looking at unintended weight loss here. We're looking at inflammatory or systemic signs. And chief complaint, of course, is arthralgia. Okay, so possibly an inflammatory arthritis going on. What are we going to do now for a physical exam? So we're going to do a pretty comprehensive exam. So she's thin and fatigued appearing. She's got some mild facial redness or flushing, but no macules or papules. Head, lymph nodes, chest, lungs, heart are all fine. Abdomen, soft, non-tender, non-distended, normal bowel sounds, but mild liver enlargement, interesting. Extremities show no joint effusions and some general pain with movement, not surprising. Neurologically, she's intact, non-focal. Okay, so what are we going to consider for our differential? Well, if you thought of lupus and RA, you are on the right track. Those are something that we always consider in young women coming in with chronic joint pain. But there are some other things that we may want to consider. So fibromyalgia, very non-specific symptoms. Chronic pain, usually in older people, but something we can consider. Lyme disease, chronic joint pain, very common if it's not treated initially. Polymyositis, or you may also consider dermatomyositis, can give you a rash and pain, usually more muscular, but could be confused with joint pain. Paraneoplastic syndrome and anemia. What are we going to do for our workup? So we're going to get electrolytes and check her kidney functions. We're going to get a CBC. We're going to get LFTs because of that enlarged liver. We're going to get a urinalysis, gives us some idea of what's going on with the kidneys. We're going to get a SED rate because we think this is inflammatory. We're going to get a creatine kinase because of the possibility of myositis. And then because we're thinking of those possible rheumatologic diagnoses, we're going to get an ANA and rheumatoid factors. And then last but not least, Lyme titers. What do we find? Well, we find that she's got an elevated BUN, elevated creatinine, so she's got renal dysfunction. Her CBC is wacky. She's got a leukopenia, she's got an anemia, and she's got a thrombocytopenia. So she's got a pancytopenia in addition to renal dysfunction. Her urinalysis shows 3+ proteinuria and red blood cell casts, contributes to the evaluation of renal dysfunction. SED rate elevated, creatine kinase normal limits, ANA is positive, so this is autoimmune. Rheumatoid factor is negative, so we can get rid of RA. And Lyme titers are negative, so this is not a patient with Lyme disease. So what is our provisional diagnosis? It is lupus. And likely there is some secondary nephritis and anemia of chronic disease. Now, lupus can cause hemolytic anemia, but typically the more common cause of anemia in lupus is anemia of chronic disease from the inflammation. Now, our further workup is really just going to be to confirm the lupus diagnosis. So to do that, we get these more specific antibodies, anti-double-stranded DNA and anti-Smith. We're also going to check complement levels and get a 24-hour urine protein. These are important to do, but not as important as confirming the diagnosis of lupus. So we find that the dsDNA and Smith are positive, nailing down the diagnosis of lupus. Complement levels are decreased, and the 24-hour urine protein is 4 grams, and that is nephrotic range proteinuria. So she's definitely got lupus nephritis going on. So the diagnosis is lupus. The management is going to be steroids and hydroxychloroquine. Hydroxychloroquine is really the cornerstone of lupus management. Everyone is going to get it unless there's contraindications. Hydroxychloroquine is for lupus and malaria, not for COVID. Okay? Now, because she's got lupus nephritis, we need to get a renal biopsy to determine what kind it is, because there's different kinds. She will need immunosuppressants because she has nephritis. That's not often needed in lupus unless they've got those sorts of complications. And then ibuprofen for pain. We need to advise her to avoid the sun and use sunscreen because that can cause flares. And then the medication side effects. We're going to refer her to rheumatology. They're going to be the ones that will manage her long term. And then we need to refer to nephrology for the nephritis and for the renal biopsy. We will admit this patient to the inpatient unit because she has active renal failure. So lupus is a systemic disease of unknown etiology, but it is associated with autoantibodies and immune complexes. 90% of lupus patients are women. Interesting fact, when I was in college, I got these weird rashes all over, including on my face, and they checked me out for lupus. I didn't have it, but we never actually got to the bottom of what it was. Steroid creams, went home. This is very common in dermatology, right? So there are typically relatively asymptomatic periods with lupus, and they're punctuated by these flares. So it's kind of like Crohn's disease and ulcerative colitis in that sense, where they can be okay for a while, and then they get these flare-ups. Lupus is diagnosed clinically and with labs. There's lots of criteria. You can pause it and read these. You should have an idea of what lupus looks like, though. The big ones are the rash, the arthritis, and the renal involvement. This is what the malar rash looks like. I included these pictures because I want you to see the distribution. So this could be as little as just this flushing on this patient. You could have some flushing and maybe a few macules and papules, or you could have really a frank maculopapular rash, or you could have no rash at all. So don't think that you have to have a rash in order to have lupus. You could just have joint pain, fatigue, and anemia like this patient. So ANA is highly sensitive for lupus, so it should be part of your screening. It should be part of that first set of labs. Once you suspect lupus, then you get the dsDNA and Smith, because those are very specific. Only about 3% of lupus patients will have a negative ANA. All right, so if that comes back negative, look elsewhere. If the dsDNA comes back positive, you've pretty much nailed down your diagnosis. The management is hydroxychloroquine and steroids. Hydroxychloroquine basically in every patient. Steroids, we really do it during the flares, and then we taper the dose. NSAIDs are given for pain, but hydroxychloroquine will go a long way in helping pain as well. And patients with lupus nephritis will need immunosuppressants, but I doubt you will be asked to pick out one on CCS. You may be asked on the multiple choice questions. Mycophenolate is typically preferred. Cyclophosphamide, remember, has those bladder effects. We want to avoid that. Okay, so some of the differentials. Rheumatoid arthritis looks very similar, presents in the same age group of patients, but you'll have a positive rheumatoid factor. The confirmatory test there is the anti-CCP antibody. Fibromyalgia tends to be more musculoskeletal, and it happens at these stereotypical trigger points. Usually older ladies have this. Lyme disease, think of it if a guy comes in looking like this. You might think Lyme disease just because lupus and RA are a lot less common in men. Polymyositis or dermatomyositis. Dermatomyositis in particular can give you a rash and those polymyositis symptoms, but those tend to be shoulder and pelvic, whereas RA, lupus tend to be more peripheral. Paraneoplastic syndrome, this is kind of where we would go if all of these other things didn't pan out. We would look for the possibility of a malignancy, especially with that pancytopenia. So to recap, lupus is a systemic disease, unknown etiology, but associated with antibodies. When you suspect it, get ANA. When you want to confirm it, get dsDNA and Smith. Low complement level supports the diagnosis. The management is hydroxychloroquine and steroids. Immunosuppressants are added for patients with renal involvement. The complications include the medication side effects. So hydroxychloroquine, the big one, is retinitis. And steroids, as you know, cause weight gain and bone demineralization. Antiphospholipid syndrome is another complication. Progression of renal disease to end stage. Some of these patients will go on to need dialysis. Interstitial lung disease, serositis, pregnancy loss, which we saw in this patient, and neonatal lupus. And you should be familiar with how to work up a pregnant patient with SLE to know if her baby is running the risk of heart block. But that's an obstetrics talk, so maybe we'll catch that later. So very important that you understand the process of working these patients up, know your most sensitive test, your most specific test, and know the cornerstone of management. All right, and that should get you a long way on CCS.